next presentation will be by Dr. Mahmoud Elsedeiq. Dr. Mahmoud Elsedeiq is one of those talented team in liver transplant in Al-Mansoura. He is graduated in 2011, earned his master degree in 2016, and his MD thesis in 2020, just before the corona in March 2020. Dr. Mahmoud Elsedeiq will talk tonight about intraoperative anesthetic management of liver donor liver transplantation, live donor liver transplantation. All yours, Dr. Mahmoud. Thank you.
Assalamu alaikum. I am happy today to participate in the MEGA online course. Today, our presentation about intraoperative management of living donor liver transplantation. Our objectives today: why the anesthetic management of liver transplantation is challenging, the anesthetic induction and maintenance, stages of liver transplantation operation, monitoring, fluid management and blood products, anesthesia for the donor. This is our great team of liver transplantation. Why the anesthetic management of liver transplantation is challenging? The multi-system nature of the end-stage liver disease make the anesthetic management of those recipients very challenging. The end-stage liver disease affecting multiple systems: cardiovascular system with cirrhotic cardiomyopathy, respiratory system with hepatopulmonary syndrome and portopulmonary hypertension, the renal system with hepatorenal syndrome and the coagulopathy, and affecting the metabolism of all drugs and toxins all over the body. Also, the major intraoperative pathophysiologic derangement, the critical anhepatic period, ischemia, reperfusion injury, and post-reperfusion syndrome, difficult post-operative course. The anesthetic induction and maintenance. The induction with rapid sequence induction, hepatic patients have a tense ascites and delayed gastric emptying. The tense ascites can make respiratory distress, so we can make slow tapping before anesthetic induction. The intravenous induction, the pharmacokinetic and the pharmacodynamic profile of the hepatic patient always affected. The patient have unpredicted response to anesthetic drugs. Also, the volume of distribution increase in hepatic patient. In those patients, we use intravenous anesthesia for induction. Propofol usually in our institute. The neuromuscular blocker, we use rocuronium. That as rocuronium short acting and can be reversed with Sogamadex. The maintenance, we use inhalational maintenance, sevoflurane especially. It has the least effect on hepatic blood flow and also has not hepatic toxicity. Rocuronium and fentanyl infusion for fast track recovery. The surgical site infection prophylaxis. In liver transplantation, the recommended agent piperacillin, tazobactam, or cefotaxime plus ampicillin. Alternatives for beta-lactam allergy, clindamycin or vancomycin, plus aminoglycoside or S-seronam or fluoroquinolones. The timing before incision, optimum 1 hour, maximum 2 hours, and the minimum half an hour. Phases of liver transplantation operation. The transplantation operation have 3 phases: dissection phase, anhepatic phase, neohepatic phase. The dissection phase started by opening the abdomen and the aspiration of acidic fluid. Most patients with end-stage liver disease have a large volume of acidic fluid. Rapid aspiration of acidic fluid can lead to hypotension and collapse of the patient, so we aspirate very slowly. The replacement of acidic fluid, either complete replacement or half replacement or according to CVB. In our institute, we use a CVB as a guide for replacement for acidic fluid. Then the application of retractors. Application of retractors can lead to bradycardia and hypotension. We ask the surgeon to release the retractors and we give small doses of atropine and fluids. If not responsive, we give small doses of adrenaline. Then we go to skeletonization of the IVC and the complete dissection of the porta hepatis. At this stage, the bleeding is a common, especially in patients with Budd-Chiari syndrome and patients with massive collaterals, or if there's severe adhesions post-splenectomy. We need massive bleeding and massive blood transfusion that can lead to hypocalcemia. So we monitor calcium ions at this stage. The anhepatic phase starts by clamping of the portal vein, hepatic artery, and partial clamping of the IVC. At this stage, loss of the metabolic activity of the liver can lead to accumulation of the lactate, leading to lactic acidosis and metabolic acidosis. Also, hypoglycemia can occur at this stage, so we monitor the blood glucose level at this phase. Coagulation problems is common at this stage, especially bleeding. Neohepatic phase started by declamping of hepatic veins and the portal veins, leading to increased inflammatory mediators. Also, occurrence of post-reperfusion syndrome and ischemia reperfusion injury that can lead to decrease in blood pressure, arrhythmia, and may lead to cardiac arrest. Post-reperfusion syndrome has a multiple definitions. The oldest definition by Agrawal et al. It's a decrease in mean arterial blood pressure greater than 30% below the baseline, lasting for at least 1 minute, occurring during the first 5 minutes after reperfusion of liver blood. Another definition by Helmi et al. Expanded the first definition into mild and severe. Mild with less than 30% decrease in mean arterial blood pressure, severe with decrease more than 30%. Fukazawa et al. Divided it into 3 phases. The first phase from portal vein declamping to 5 minutes post-portal declamping. The second phase from 5 minutes post-portal declamping to arterial declamping. The third phase from arterial declamping to 240 minutes post-portal declamping. The etiology, global hemodynamic aspect, the response of cardiovascular system to cold acidotic wash fluid, and the air emboli in the graft leading to ventriculo-arterial decoupling, metabolites in the graft and intestine as interleukin, tumor necrosis factor, and electrolytes. As a risk factor, cirrhotic cardiomyopathy and RV dysfunction. The management, we manage it by IV fluids, vasopressors as noradrenaline, and small boluses of adrenaline. Also, extracorporeal graft trends may decrease the impact of post-reperfusion syndrome and the preconditioning. This paper registered in clinical trial by our institute, norepinephrine boluses for prevention of post-reperfusion syndrome in living donor liver transplantation. The recruitment status completed and the study will be submitted very soon. Another article published from our team, short-term effect of extracorporeal graft trends versus circulatory graft trends in living donor liver transplantation, a prospective randomized controlled trial. In the conclusion, we concluded that the circulatory rinse technique induced the early significant short-lived turbulent hemodynamic changes after portal unclamping that were clinically controllable, yet this didn't influence hemodynamics nor clinical outcome beyond this point, justifying its use in relatively healthier recipients with lower MELD score. Ischemia reperfusion injury. The ischemia reperfusion injury that occur from anaerobic metabolism and acidosis leading to cytotoxicity, increased cellular edema and metabolic dysfunction, mitochondrial damage and apoptosis. Also, the oxidative stress increase the ROS and interleukins and tumor necrosis factor, and the intracellular calcium overload. Ischemia reperfusion injury has a detrimental effect on the liver graft. They can lead to primary non-functioning graft or early graft dysfunction, can lead to acute kidney injury, myocardial infarction, intestinal edema, and the early alias post-operative, and also disrupt blood-brain barrier and can lead to brain edema post-reperfusion. To decrease the ischemia reperfusion injury, we can use the steroids in our institute. Also, another trials by the use of antioxidant as N-acetylcysteine or mannitol to decrease the ischemia reperfusion injury. Venovenous bypass. Some centers use venovenous bypass to decrease the ischemia reperfusion injury of the intestine. Monitoring during liver transplantation. We use the standard ASA monitors, hemodynamic monitors, neurological monitoring, proton, EBG, electrolyte, and lab. Hemodynamic monitor, pulmonary artery catheter. We use the pulmonary artery catheter in special indications as patient with portopulmonary hypertension, patient with cardiac disease, or patient with renal impairment. Pulmonary artery catheter give us accurate measurement of pulmonary artery pressure, stroke volume, cardiac output, temperature, and central venous oxygen saturation. Transesophageal echo is a very important method for monitoring in liver transplantation for goal-directed fluid therapy. Also give us information about wall motion abnormalities, contractility, and RV function, assessment of the valve, left ventricular outflow tract, pulmonary artery pressure assessment, and the presence of any thrombus. Invasive arterial pressure monitoring for changes for blood pressure beat by beat and the need for vasopressor and electrodes. This is the picture of pulmonary artery catheter. This is the four-chamber view of transesophageal echo, and this is the monitor with invasive arterial blood pressure. A published article from our team, The Impact of Portopulmonary Hypertension on Intraoperative Right Ventricular Function of Living Donor Liver Transplant Recipient. We concluded that mild to moderate portopulmonary hypertension was associated with reduced RV ejection fraction during liver transplantation, especially after reperfusion, likely because of the reduced RV contractile reserve in portopulmonary hypertension patient. This reduction in right ventricular ejection fraction was clinically well tolerated by patients with mild to moderate portopulmonary hypertension. Hemodynamic monitoring. This is a monitor. The first monitor, the patient with pulmonary hypertension, we found the mean pulmonary artery pressure 53. The second picture, after application of retractor in one case that occurred bradycardia, post-reperfusion, the blood pressure in the third picture decreased, the mean decreased to 34. Also, post-reperfusion in another case, the mean arterial blood pressure decreased to 42. After administration of vasopressor post-reperfusion, the blood pressure increased and the mean became 72. Also, at the time of reperfusion, the capnography decreased to 60. This is the views from our patient with transesophageal echo. This view is transgastric mid-esophageal, transgastric mid-papillary short axis view. We use this view for assessment of the contractile function and the whole presence of wall motion abnormalities and the hemodynamic assessment. This is a four-chamber view for assessment of the valves and the RV function, also assessment of the LV function. The third view, RV inflow, outflow for assessment of aortic valve, intraatrial septum, the tricuspid valve, and pulmonary valve. Coagulation monitoring. Liver is the organ responsible about the balance between coagulation and the anticoagulation. This balance lost in end-stage liver disease, Neohepatic phase, and ischemia reperfusion injury, coagulation-related dysfunction. Also, massive bleeding and massive blood transfusion needed in liver transplantation make us use a rotem as a guide for coagulation management. The role of antifibrinolytics. Hyperfibrinolysis may occur post-reperfusion, so we use the rotem as a guide for us to use antifibrinolytic. Some centers use a protonin for protection of ischemia reperfusion injury and decrease the use of blood products, but in our center we don't use a proton. This picture from our patient with proton. The second picture we found here, there is a hypocoagulopathy. Here there is no a clot formed. Also here there is a hyperfibrinolysis. Neurological monitoring for monitoring of depth of anesthesia by spectral index, adequate muscle relaxation, training for fast track recovery, and intracranial pressure monitoring, which has a special concern in liver transplantation, especially in patients with acute liver failure. Most cases with acute liver failure has increased ICP and may lead to brain herniation. Also, the ICP increased post-reperfusion. So there is a multiple method for monitoring of intracranial pressure, either invasive or non-invasive. Unfortunately, the invasive method has multiple drawbacks, as bleeding, as most patient with most hepatic patient has coagulopathy. So we use non-invasive method like optic nerve sheath diameter. This trial registered in clinical trial optic nerve sheath diameter as a predictor of early tacrolimus neurotoxicity in living donor liver transplantation. Is still recruiting the cases. Fluid management. Large fluid shift and excessive bleeding had a special concern in liver transplantation, so we insert two large bore IV line at the beginning of the operation. The fluid therapy, according to ball-directed fluid therapy. Types of fluid used: for maintenance, we use ringer acetate. For loss, we use colloid albumin 4%. Availability of packed RBCs, fresh frozen plasma, and platelets. The use of cell salvage is crucial in some situations, as Budd-Chiari syndrome and the patient with massive collaterals, or if there is severe adhesion post-splenectomy. Fluid warmer and infusion bulb for infusion of large amount of fluid up to 2 liters in 1 minute. Also recording of urine output every hour. Temperature management. There is a multiple causes of hypothermia in liver transplantation operation, as it is a lengthy operation, transfusion of large amount of fluid and blood products. The hypothermia has a detrimental effect on the body, as coagulation abnormality, decreased response to vasopressor and necropes, metabolic acidosis. Hypothermia also predisposed to arrhythmia and infections. The management of hypothermia, we use a warming blanket, fluid mattress, fluid warmers, and the temperature monitoring by pulmonary artery catheter or nasopharyngeal temperature probes. Electrolyte, EVG, and lab. In the dissection phase, the bleeding and the massive blood transfusion can lead to hypocalcemia, so we need to monitor serum calcium at the dissection phase. The end-stage liver disease also can lead to hypomagnesemia, which can lead to long QT interval, hyponatremia or hypernatremia or hypokalemia. The anhepatic phase, decrease the citrate metabolism, can lead to hypocalcemia, decrease the metabolic activity of the liver, lead to hypoglycemia, and the accumulation of lactate lead to metabolic acidosis. The neohepatic phase, especially in cadaveric liver transplantation, hyperkalemia may occur. Metabolic acidosis, especially in early non-functioning graft, and the accumulation of lactate leading to lactic acidosis. Renal protection. Liver transplantation characterized by bleeding and large fluid shift, IVC clamping, and periods of hypotension and ischemia reperfusion injury. All of this can lead to acute kidney injury. For protection, we maintain the patient eovolemic, maintain the mean blood pressure more than 65 millimeter mercury, hemoglobin more than 7 grams for normal renal function patient, and more than 10 for patient with renal impairment, and maintain the euglycemic state. Donor anesthesia. The donor is a normal person without major comorbidities. Anesthesia started with IV induction, propofol, reclonium, fentanyl. Maintenance with inhalational anesthesia and infusion of muscle relaxant and fentanyl. We insert two large bore IV lines, CV catheter, standard when use standard ASA monitored and CVV. We maintain a low CVV at the parenchymal dissection stage, and which has a great concern with the post-operative analgesia. Thank you. أنا مش سامع حاجة. حد بيتكلم؟ هو الصوت ده مش طالع. الصوت
سؤالك كان سؤالك ترد انت دكتور سعد. تسمعني كده يا محمود؟ تسمعني؟ There is a problem with the donor anesthesia because I found that more than 33% of the voters voted that the donor may have a major comorbidity, which is not true. The donor should be perfectly safe. You cannot accept donors from ASA2 state. So as all donors should be ASA1. The only accepted is controlled hypertension and controlled diabetes no more than 5 years. Otherwise, normally you don't take any diseased person for donation. So the donors are not supposed to have a major comorbidity. Thank you very much. For the question about triggering for blood transfusion, usually we use the same as a trigger for blood transfusion, but taking in consideration that those patients usually have the values of the blood picture usually lower than that of the normal person. For example, they are accustomed for hemoglobin of 10. There is always thrombocytopenia, which should not be corrected before the operation, so long as there is no bleeding tendency. So normally we use only the triggering of the hemoglobin. Hemoglobin may be probably up to 6 grams per DL. We start transfusion at this point. For the plasma, it's just the coagulopathy if started. And for the platelets, we usually don't give platelets, even with platelets up to 30, 35, so long as there is no problem in the surgical field. Thank you very much. No, of course, 7 grams hemoglobin is not safe if there is mild to moderate degree of pulmonary hypertension or patients with probability of low cardiac performance. In this way, we try to keep hemoglobin 8 to 10. For the compound A hepatotoxicity, we actually do not usually assess this problem, but we didn't meet any problem induced by long-term use of sevoflurane. Although we use the low-flow oxygen, but I can't say that if we had a problem or not, because we usually don't assess this. For post-operative pain management, we use IV opioids incremental in the recipient because we don't have a problem of post-operative pain in the recipients. Usually, the recipient operation is associated with cutting surgically most of the nerve supply of the anterior abdominal wall, and usually we don't have pain in the recipient, so there is no problem with most of the incremental doses of the IV opioids. It's just fine for the first 6 to 8 hours, and after that there is no need for analgesia at all for the recipient. The problem is with the donor, and we use
طب هي عايز تطلع كلمتني تطلع امتى طيب؟ عمرو يخلص ولا حد هيقدمها دي ولا ايه ظروفها؟
Yes, of course, it's for the blood sugar should be controlled preoperatively. We use the hemoglobin A1C to be sure that the patient is a little bit controlled before the operation. But sometimes the operation for liver transplantation is a little bit semi-emergent operation and don't have time to control it accurately, and you can continue this process after the operation. No, usually don't use desmopressin to improve platelet function in these cases because there is the main problem will be thrombocytopenia transfusion if we need it, but we didn't make usually major problem with hemostasis, so we gave platelets maybe in less than 10% of the cases. No, in our program we don't use any regional flux in the recipient because of the coagulopathy and liability for infection after transplantation by the immune suppression. But we tried previously, and we published this about the bilateral tab lock for the donor, and it was a success. Transplantation and COVID-19 is a very, very interesting subject, yet it's not studied so far because of the number of the transplanted patients got COVID-19 is not that much, because they are usually highly conservative patients and they preserve themselves at home. They are the easiest patient to follow the protective measures. However, I have witnessed more than 4 patients who had renal transplantation, and they are doing very fine. The disease was mild, probably because they are on steroids. Usually the program in our urology center is steroid based. Maybe this ameliorated the disease activity in them, and we didn't have any patient with liver transplantation so far, and our program have COVID-19. Yes, we prefer the fast, not the ultra fast. Ultra fast extubation means extubation on the operating theater, on the operating table. It carries a risk of transporting the patient without being airway controlled. We do what's known as fast extubation. Usually extubate the patient within 30 to 60 minutes from being in the ICU. No, we use only tranexamic acid based on the results of Rotem, and we use it only in 2 patients, no more.
Dr. Amr is muted.
Yeah, this is a very nice question, actually. Yes, in our program, if we suspected by the clinical presentation of the patient that he has a pulmonary hypertension, while the transthoracic echo demonstrated a normal pulmonary artery pressure, we usually insert a catheter in this patient preoperatively 2 days before listing the patient. And if he is mild, we proceed. If he is moderate, we decide with the cardiologist whether to give him a short trial, 30 days of sildenafil or not, according to the condition of the patient. Thank you for this question.